This is going to be super bold. Not many doctors would talk this language. There is a lot of information about female fertility challenges on the internet, but there are not as many resources about male fertility challenges. Often many men also can't be vocal about what they were going through. In this podcast, Dr. Sunil is going to pinpoint what are the causes of male fertility conditions. He surprisingly says most of them can be reversed with better lifestyle and you will not need an IVF in many cases. So please watch this till the end so that you can make an informed decision making, and why rushing is always not right in terms of making your fertility decisions. Please watch it till the end and take a decision for your family and your fertility journey. So you have seen thousands of couples who are having fertility problems, and I believe a lot of information on internet or a lot of advice is for the women. You have this problem, etc., and disproportionately less information for men. So what percentage of fertility problems are by male partner? Is it even significant?
Actually, to be really frank, the incidence or the reason, men being the reason for infertility, has increased quite a lot in the few years, or probably a decade now. There was a huge article or probably a series, I'm not able to exactly recollect, called as Spermageddon. That means to say it's like, sperms are coming down. The average number of counts is actually coming down. So when we look at the fertility per se or infertility, when we do a investigation, there are certain battery of tests on the women, and the men, it's only very simple one, semen analysis. Okay. And now the semen is, whereas in a woman, we're still not able to see the egg. We only have a surrogate markers. And where the men, we can directly see the gamete. But there are so many things about the gamete that it becomes not that easy, because whatever said and done, we have come so many years into the research and things, but then still I think there are lots of things yet to be solved. When you talk about sperm, again, you know that there is one egg and there are millions of sperms to fertilize one egg. So that itself says is nature that it's skewed in such a way that anything wrong with the sperm, even a small micro minute thing, can affect the chance of fertility.
Right.
Because you need millions. Now out of these millions, and if you have things which are affected, so it will be. So when we look at semen analysis, there are a few factors which you look at. One is the count, which is essential in sense that how many number of sperms can swim up to the egg. Next is the structure.
Number of cells in 1 ml or given volume.
Yes. We count it in million per ml.
Million per ml.
Minimum we say 15 million.
Right.
Okay. And next is the structure of the sperms, which we call it as morphology. This is where most of the time we have a issue, because what is really a normal thing is defined by the head, neck and the tail or the body. So many different technicians see it in a different way.
Right.
Where someone may say that, okay, this is an abnormal head. The other technician may say, no, this is a normal head. Or the neck is different, or the tail is bent and things like that. So that's why the WHO came up with very strict criteria, and we said, okay, even if we have a 4% normal out of this millions of cells, it is still a normal sperm. When you call it as a normal sperm, now again the WHO has really clarified on that. When you talk about normal sperm or semen, is that they have only now written as whether you can conceive or not is not the question. They said, what is the probability that you can conceive with this kind of sperm? If you have an excellent sperm morphology, they say, okay, 50, 60, 70% of you are falling in that bracket of the, and most of them who are looking at the YouTube and things, they will definitely know the bell curve and things like that. So there is a segment of sperms which fall below the bell and 5th centile and above
so the probability will get impacted.
We are only talking about a probability.
Possibility is still there.
Yes. So even if it is a 5th centile, they do not say it is zero chance. You could still conceive, but then the chance is a bit less. How I give it as an analogy is, if you place 100 students in a line in the rank wise, you cannot discard the last 5 ranks and say no, they can do nothing in their life, right? So it's something like that. You are in the 5th centile. You know, you have one person morphology, you have less than 15 million count, you have only 10-15% motile. You're still in the 5th centile. You could still conceive, but it may take time. When exactly? But you can't even guarantee that if you have a normal sperm also that you can conceive in the next cycle, right? So that is why WHO says that okay, tell that this you are falling in this bracket of normalcy. They don't tell that it's a normal sperm. So as there is so much of ambiguity in the way we look at the sperm and count and motility, and with the number of labs which are coming up and have come up, we do see reports which are quite varied in sense that the way the interpretation is. So we would generally prefer analysis which are coming from any fertility centers, because we have an andrologist or a embryologist who's looking into the sperm, so they have more experience, so they are more qualified to comment on the sperm. So semen analysis is one of the most important.
So urologist and andrologist?
Andrologist or embryologist?
Or an embryologist.
Embryologists are the one who needs to look into this. But as I said, because of the ambiguity, we never say you can never conceive until unless you have a 0 count. That's another thing which we have seen, that once it's a 0 count, it's not necessarily it has to be 0 count 1. It has to be at least again confirmed with 1 or 2 consecutive tests to say that okay, it's a 0 count.
Because there can be a possibility of error in this test?
Because 2 things, yes. It's not that every day, every time you're producing millions of sperms. Yeah, there may be sometimes you have had a stressful life, or you have had a chronic infection, or you are suffering from fever. Typically in India, there could be typhoid or malaria. If you're having that few months back, then your count may still be very low, or sometimes even undetectable, which could probably pick up over a period of time. And but in 0 count it's less, but we call it as oligoasteno. If it is oligoasteno, we generally we give some time on it. Another thing which we also have seen is something called as retrograde ejaculation, where the sperms get ejaculated to the urinary bladder, then coming out, so it get ejaculated into the bladder. So whatever semen you get, it is actually the seminal vesicle fluid and the prostatic fluid which coming. So we do not see any sperms. So that can also be.
So ejaculation is happening, but sperm cells are not.
Yes, sperms are not coming in. So that is also one possibility when you talk about 0 count. Yeah.
So so is morphology is the major factor that because of which natural conception is not happening?
See, as I said already, morphology, very strict criteria if you follow. Minimum 4% is what they say, minimum, but then now WHO says okay, even if 1 or 2%, they fall into 5th centile or a 10th centile. We can put it on the curve, you generate a computer report. Morphology, yes, of course, because that's one of the thing which can get affected very easily by your lifestyle, your environment, your stress, and all the other genetic factors too. And morphology is difficult to assess. Sperm, on this sample of sperms which we get, suppose what we gave last week to this week, it may be different. So that's the reason when we see a report which is a bad morphology, we always tend to repeat the semen analysis one. Even if you say normal semen analysis and you are not able to conceive after 4 or 5 months or 6 months, we tend to repeat the semen, because as I said, semen is very, very dynamic. We can never, conclude with 1 semen analysis or 2 semen analysis, yes, you are super fertile kind of thing. No. So it can always keep changing. So if you are not conceived over a period of maybe 4 or 5 months, it's always good that we can repeat a semen analysis and see if there is any changes which are happening. Morphology is also associated with bad pregnancy outcomes. So very low morphological index is associated with recurrent pregnancy loss too. Yes, of course.
Because a healthy sperm didn't fertilize with the egg, and that's the reason natural selection is happening.
More than that, I would say like DNA fragmentations happen, so it's more to do on the genetic level. So, so the healthy embryo formation may not happen, so probably end up in having more of a genetically compromised.
So the, let's say 5% is the morphology, 95% sperm cells are not structurally healthy.
Yeah.
So though those cells are fertile, one of those cells.
No, generally what is it's what we also say. No,
Sorry,
that,
I think like an engineer, so I'm asking that question.
So I think this joke you must have heard. If you should be very happy that don't consider you to be unlucky or what, I'm not bestowed or I'm not the best person on this earth kind of thing, because for you to be born, you were one among the millions.
You are already a born winner,
right?
Yeah, you are one in a million.
It's like that. So it's only the healthiest sperm which can actually fertilize the egg. But unfortunately, sometimes yes, it can happen. But we cannot completely blame it on the semen, because this phenomena of which one fertilize what. When we talk about IVF, we know, okay, this is the good looking sperm, it's got all the morphologically right things, and we inject inside the egg. But unfortunately, even in spite of that, we end up having a bad outcome. So we cannot completely blame on it. But when we have a bad semen morphological index, even IVF outcomes are affected. So probably yes, as you said, though even it may look normal, it may still be carrying some kind of a DNA defects which could result onto the abnormal outcome.
Right. So when morphology is low, how should a couple take an informed decision? What options they have? Can that be improved by lifestyle, or is IVF only the way to go for conception? What is your take on it? How can someone take an informed decision?
Ravi, I think you also seen too much of Google. Huh? Okay, so there are, to be very frank, I don't think there's any algorithms as such for us to say, okay, fine, if this is
then this
right,
is the way.
This is the way. If this is right and this is wrong, then this is the way. So we do not have that kind of an algorithm. But what I would say is, if the morphology, generally what we have seen is, along with morphology, we've seen most of the time even the motility is affected. Though the count is something which can be affected over a long period, after a long period of exposure of whatever the insult is happening. But usually the morphology and the motility are equally affected. I've seen reports where they say count is low, motility is low, but morphology 100% normal, 80% normal. Generally, it doesn't happen. Okay, and we repeat the sample and see, okay, it's all the parameters which are affected or some parameters. But morphology is if it is affected or motility is affected. First question which the patient asks, not about the the journey to the fertility. For him, it's the first question: how did this happen? Why did this happen?
It's hard for a male to take it.
Yes.
How can this happen to my...
I'm a super male, I go to gym, I exercise, I'm fit, I don't... And another thing which I keep hearing, sir, I don't even smoke. How did this happen? And then we need to look into that. So whenever there's a morphological problem, we get into the more of details of their history. What we have found is the stress level of a patient or the person is generally on the high side, and lifestyle is quite disturbed. So lifestyle doesn't just mean that it is about healthy eating or proper drinking. It is also about what you eat, how much you drink, how much sleep, how long you've been sitting, and what is your exposure to the other environmental toxins. So those things are all one of the crucial things. To give you some examples, I have few patients like few months back or years back also. We tried everything in India here, Bangalore. We tried normal try, we tried IUI because of some semen abnormalities, and these were typically IT professionals. And they said, okay, fine. We want to take a break in sense that we are going to be posted. I'm getting a promotion. I'm going to Europe, or I'm going to US or Australia. And I've seen that some of them, just with the change of environment of here to there, and we get a call because we generally tend to follow up with patient and say like, yes, we have conceived.
Yeah.
And like, how did this happen? Because we tried everything which is available and things. And looking back at their history and things, we realize that stress plays a huge role, and lifestyle definitely. In India, on an average, if you're commuting, even a 10 kilometers in Bangalore, you are taking almost like 1.5 hours sitting on either on the bike or in a car. And what we have keep telling about the new studies are like sitting is new smoking.
Right.
Now you're smoking for an hour.
Yeah.
Now that is a kind of an impact. So morning 1 hour, evening 1 hour. So you kind of
Yeah.
plus the stress of life in your industry. So that all works on it. But over a period of time, it becomes a norm. I go to office, I come back from office. Correct? You don't say that, oh, I spend so much time in the commute. So that's one thing. Then next is the healthy lifestyle, because that makes a huge difference in sense, what we eat, what we drink. I think in one of the last talk, I had also said that there is a large amount of nanoplastics in the environment, and we've also seen
endocrine disrupting chemicals.
Yes, there are lots of those are there. So what is endocrine factors? If you look at the list is huge, and it is there in most of our processed foods. So when we talk about the norms of regulation on this, they say minimum, the advised value. But is that minimum also advised to you? Why do you have to take that minimum also? So that is there. So what we have seen, particularly when you talk about oligoasthenospermias or asthenoteratospermias, is that no much of results we get when we do any kind of investigations. In sense, we do the hormones, we look at the bloods, LFT, RFTs, we look at the scans, testicular scans are done to rule out what is called as varicocele. Varicocele is one of the reasons for a reduced count.
It obstructs the...
It is basically what is the whole anatomical or the physiological thing about testis is, it is outside the body, it's not in the body, right? So generally it is lesser temperature when it's in the outside. So when there is varicocele, is basically there is increased number of blood vessels which are going into your testis, right? So when there are increased number of blood vessels and increased number of amount of blood which is flowing in your testis, it is heating your testis.
Right.
So basically it is counterproductive to what nature had already designed to you. Okay. So if the varicocele grade 3, grade 4 is there, that means there is huge amount of blood flow which is happening. So it is heating up the testis. So that could be the reason for reduced count and motility. But recent researchers says that even getting rid of varicocele thing is not improving. So that there is something innate or something which is acting without your knowledge in sense. So whenever we do this investigation, we have not found, maybe if it's 100 patients with severe oligoasthenoteratospermia, we generally find 4 or 5% to have some kind of a varicocele in it. Some of them may be diabetic, that's another thing. Some thyroid abnormalities or prolactin abnormalities may be there. All this put together, maybe 10 to 15% where we will say, okay, there is something which is attributable. Another 75 to 90%
we can't attribute the reason.
No particular reason which we can find out through our investigations.
Oh. That's frustrating actually, like when somebody says, hey, this got wrong and why it went wrong and what should we do to get it back. On that note, I want to ask one question. I think healthy lifestyle, because of Instagram reels and so many influencers out there, it became an abused word. So men are also hearing that, you follow healthy lifestyle, your sperm health will be taken care of. What exactly I should follow? So can we pinpoint this intervention will help in this particular case? Or we can't pinpoint that and there are some general guidelines that everybody facing these challenges should follow. What is your take on it?
So regarding the first thing which you said, when everything is right, why still, why there is no question? The analogy for it is, Because I generally like to give analogies to everything. It's like a first question I ask is, what is the percentage of marks did you get in 10th standard? They're like, okay, some say 90, some say 80, things like. So and then the question is, did you not study for it? Did you not put your 100% effort?
Yeah.
Yeah, I put 100% effort,
Yeah.
but still this is that. That's
Yeah.
how it is. Right? There is no explanation to everything.
Yeah.
Right? Nature is such that we cannot explain everything.
Right.
Coming to your question per se, see, there are only general guidelines. Okay, there are certain food things, there are certain exercise, there is certain way of being which help in general improvement. Only if general improvement happens, then the sperms will also improve.
Right.
If you say, okay, I'm not going to eat sweet, but I'm continuing to smoke because smoke is going to affect only my lung, then it's a wrong concept, right? So similarly, you need to wait for also a certain period of time for things to work for you. So there are only general guidelines. Basically, certain exercises, certain food, certain medications probably, and I always say weight loss. Weight is another thing because it's like your body weight. If it's more fat is there in and around your abdomen and on thighs, then it's compressing your testis, right? You're putting a pressure, and obviously it is heating. It's in a furnace now, right? You're sitting for such a long time with so much of weight on it. How do you expect the sperms to improve, right? So there's something like weight loss. And weight loss is not that you can only reduce on the abdomen. So it's a general.
Can't be in a specific part.
Correct.
It's general.
So in that way, it's all general. There are general instructions. And another thing which I have seen particularly I'm sorry to tell, we both being males, but then that is our habit also. We are very impatient.
Right.
Okay, we want to have results quick.
Right.
I will do whatever you say. It's like this is how the patient. Whatever you say, I'm gonna do. Right. In 1 month, it will be all fine. No, it's not going to be that.
Like give me a pill and get done with it.
No, next 1 month, I will not smoke, not drink, not go to office. I will not put the laptop. I will not do this, that, everything. I'll follow all instructions. Will that be there in 1 month back to normal? No, it doesn't happen like that. Because another thing which you need to understand about the sperm production, it takes almost like 120 days to 100 to 120 days for one sperm to be produced. So you do your changes within a month and then you say, okay, fine, you are ready for it. No, it's not going to happen. It's going to take time. And it also the quantum of injury dictates the duration of your change. Now suppose you've been having this kind of a condition, or you are taking chronic stress, smoke, drink, weight, sugar, it's been there for quite some time. You need to wait for things to happen also. So that's when the planning is more important. Like how long do we wait? Okay. So minimum, what we suggest is minimum your lifestyle changes 2 to 3 months.
2 to 3 months.
We repeat our the semen analysis usually after 8 to 10 weeks just to see if there is any improvement, and probably it also gives them the encouragement. Oh, there is some improvement happening. Let me do this for more time. So 8 to 10 weeks is the ideal time to just to repeat a semen analysis. But yes, sometimes male fertility takes a very longer time to improve. So naturally. So that's when we need to kind of balance out regarding your age, because many a times they come late and already the female partner is around 35, 37. Then I can't tell them to wait for a year or so or 6 months, and then we do not. Here we are looking down at the oocytes also. We're looking at the pregnancy outcome in the women. And so that's where the balancing act is needed. But it definitely takes good amount of time for sperms to improve.
Minimum 3 months.
Minimum.
3 months.
Of course, yes.
Thanks for sharing that it takes about 90 to 120 days for sperm cells to generate and come out. And many people also say like we changed our lifestyle 3-4 months later, all the parameters we saw improvement. Or one person told me like he used to drink 60-90 ml of alcohol every day. He just stopped that. Forget about like nutrition interventions, but he could see an improvement in the sperm count and overall sperm health parameters. On this note, I want to ask one more question. like you mentioned it very clearly, there is no algorithm. If this is the answer, right? But you have decades of experience. Can you tell about the scenarios, ballpark scenarios, when an IVF would be required in case of male fertility challenges, when probably they can go for trying with healthy lifestyle for some months and or go for IUI, not needed to go for IVF. Can you just give us some instances when an IVF would be absolutely required for conception?
Okay. So absolute requirement for an IVF, one is where it's a zero count. Okay. Zero count also there are we generally categorize, many different categories are there. How we generally look at when it comes to treatment, because we need to practically look at it as 3 reasons of zero count. I generally give an analogy of a bike with a engine, or obviously any bike has to come with an engine, and if the bike has to perform really well, imagine you're having a super bike, and it needs to obviously sperms are like a super thing. So
you are comparing engine with the testicles.
Of course, yeah. So engine is a testicle and you are the bike.
Right.
So for the engine to work, there are a few things which we need other than its own mechanism. So when there's zero count, there are 3 main things. One, if your engine is performing, you have every right thing, you have oil, you have put the petrol and things like that, and your engine is working, but somehow it's not able to perform. Starting and stopping. Anyone who has ridden the bike knows that there is some kind of a obstruction maybe to the exhaust which has happened, probably because of the dirt which has accumulated and things like that. So if you just clear that kind of an obstruction, the engine would work.
May see the results.
The obstruction, that is what we say in our normal thing is, it's an obstructive azoospermia. So when you talk about obstructive azoospermia, there are a few things. One is genetically the vas difference, or the pipe which carries the sperm from the testis to the penis, is absent. So that needs some genetic investigation. In that case, absolutely you can do nothing about it.
Right.
Next,
it's like there is no silencer.
Yes, there is no silencer, of course. You need to buy a silencer. Unfortunately,
you can't
in humans,
do that with
whatever
humans,
is there, you just have to adjust with that,
right.
right? Next is when there is some kind of a trauma or injury happened to the vas difference which has caused the blockage. So if it is something because of infection, then there is a multiple layers where it could be obstructed, so very unlikely that we could clear. But if it's an early stages of infection, probably antibiotics and some treatment can help. But if it's been a chronic, we could not, we can do nothing about it. Next is some kind of surgeries which can also lead to, but as of now we have very, very kind of a safe surgeries, but we've seen anyone getting this hernia surgeries done 15-20 years back or 30 years back, that we have seen the many patients have a obstructive spermatic cords. And next is if they've had something called as orchidopexy, if it was very late surgery, then also the spermatic cords can be damaged and that can lead to it. But even if it is a zero count, as I already told, repeat the count at least another once or twice to make sure it's on. The second thing is where there's no petrol in your bike, so your engine doesn't start, right? So this we tell it as hypogonadotropic hypogonadism. That means your body is not producing enough amount of hormones. So we have to supplement those hormones. Once you supplement the hormones, it's fine. So this is one good condition where you just have to take the supplementation. Within 8 to 10 weeks, you will have a normal count, and then you can normally conceive. You don't have to go for any other ART procedures.
Right.
The third one is where your engine has failed because of some mechanism inside is really gone, or you're worn out of the engine. So where we have an option that only option is to replace the engine or get a new bike. So that's called as testicular failure, which can happen either because of genetic condition or because of some kind of an infections, which can cause the testicular failure. This can be confirmed by the blood test. And by scan to look at the size, but both of them has to be correlated again. It's not that only scan is enough to say okay, your testes have completely failed. Even though we get a total testicular failure cases, we generally advise them to have one biopsy because many times around 25-30% chance that we can still find some kind of a spermatids in this testis to be there. Very less number as they are not able to come out considering the number. So probably it is coming as 0. So this can still be used for IVF treatment. Yes. So this is about the 0 count. So 0 count definitely needs some kind of a treatment, and then we will have to, depending upon the results, we decide on going for IVF. Whereas when we talk about semen abnormalities leading to the requirement for ART procedures, there is no absolute reason. However, is the Azoospermia may be there. We generally advise them for some amount of treatment and lifestyle changes, repeat the semen analysis after some time and see if things are going well. Yes, if it is improved, you can always try normally. If not improved, then depending upon your count, we could decide on whether it is good to go for an IUI or you need to decide on IVF. Then there is another thing where there is some amount of mild semen abnormalities, but there is also coexisting problems in the women.
Right.
So it's not that we only have to see the male or female and decide about IVF. When we see that there are multiple small factors which are contributing to it, and then obviously we may have to suggest IVF. But whatever said and done, other than the 0 count, most of the things we still suggest them some amount of lifestyle changes
and
some amount
try
of treatment.
for natural conception.
Of course, if not natural, IUI. If things don't improve, if that doesn't happen, yes, of course, IVF is there.
So as a first line of suggestion, there is no need for somebody to suggest an IVF if there is count, but morphology, motility is lower side, like not too lower, but at least 5th, 10th percentile, that kind of lower. There is no reason for them to go IVF straight away. Is that something we can understand?
Now, I will again give an analogy to that.
Yeah, please.
We only understand analogies, right? So, now it's like you have a child, or you have a, you're in a school and you did the exams, out of which few people got 0 and there's no hope. And there are some people who would have definitely got 35% as a mark. Suppose someone has got around 28 or someone has got around 20. Will you say, okay, no, you can never write the exam, you can never pass, you just get out, do whatever job is suitable for you? No, right? So it's something like that. You need to give some chance to them, right? It may improve, may not improve.
Right.
We are not the ones we can. What we have seen, let me be very frank to you, Ravi, in this, that if we get 100 patients with a, there is severity of it, but then if I say it's a moderate to mild to moderate kind of semen abnormalities. Though this is our own personal, classification, mild, moderate, severe, and all. It's nothing that no books mention. It's a severe oligoasteroid. It's a moderate oligoasteroid. There is no cutoff percentage.
It's zero binary.
Something like that. So we have seen that even in this mild to moderate. Almost 90% of them have a good improvement with some kind of a lifestyle change or on the medications and things like that. And many of them conceive normally. When it's a severe, that means we are bordering towards almost like 0 count or Azoospermia. Then it is a little bit less. I would not say that they are also 0. But there is some almost 20-35% of them still can conceive with their things. So I'll tell you, recently we have done one semen analysis where I myself saw the semen because my andrologist said, sir, this is, most of them are dead sperms and count is only around 8 to 10 millions and most of them are dead sperms. So dead sperms, you cannot assess the morphology. And then I said, okay, we asked all the history and patient was a baker. Basically, he was working in one of the star hotels and then he was a baker and he said, sir, this is my job profile. Then we suggested few things. Obviously, when you're baking, there's so much of heat.
A lot of heat exposure.
And you're wearing aprons and layers of clothes and things like that. So, we suggested certain lifestyle changes and said, see, listen, do these things, and maybe after 3 months, we will have a look at your semen analysis. He was only around 35 years and wife was 29. So we said, okay, we have
we
time.
can give some time.
We have time. Come back after 3 months, we will, see it again and take a call. Till then, be normal, do whatever you want to do. Okay. He comes back after 6 weeks. And I said, इतने जल्दी क्या करना है यार? I'm not going to do your semen analysis. नहीं सर, उसकी ज़रूरत ही नहीं है. नहीं क्यों क्या हुआ? Sir, she is composed. ठीक हो गया ना.
Right.
So you need to understand the occupation. You need to understand the things and correlate and give an advice. Yeah.
But do you think like many men who has, let's say, still there is sperm count and morphology, motility is not in the satisfactory range? IVF is coming as one of the most recommended suggestions at so early. Do you agree with this? This is happening as a general advice in the practice out there, and people feel okay, I don't have an option, and males also go through a lot of trauma accepting that, and in that rush and to get that results faster, they're adopting IVF. Do you think this is happening as a practice outside?
It is happening as a practice, I would say, but another thing which you need to also understand the psychology of the patients who are coming to you. You know, they've already tried for a few years and they want a result now. And whatever you suggest, I'm not.
They don't want to try.
I'm not going to
with lifestyle.
No. That's become a kind of a norm, because if you tell me you went for a counseling and then you've seen many counselors. Out of 5, if 4 say this is the thing, you'll have to go. And the 5th one say, no,
your lifestyle se
that means you are wrong, right? So this is what we've seen, both your, maybe in the social media also it is there, and the way the approach by the clinicians also is there. So in that thing, in that whole psychological situation, patient tend to go towards what can be a quick fix.
Very quick fix.
Next is, as I said, men are we are quite impatient about things, and then if बच्चा हो गया तो then they'll say okay fine, बाप का ठीक है, is done. So however it happens, it's fine, जल्दी कर लो. But unfortunately, in all these things, that women has to undergo the whole process of so many injections, treatments, and things like that. Surgeries also sometimes. So, but yes. It is always, advisable for the patient to take a pragmatic look at it. This is my age. This is my, wife's age. This is her egg count. This is her, the tubes and things like that. If it's all fine, what's the harm waiting for another 3 to 6 months? What do you lose?
Right.
So it's just that
that mindset,
mindset that would change along with.
How hard is for you as a fertility doctor to ask a male for semen analysis, or let's say the test happened and the parameters are not satisfactory? You have to tell that male partner, here is an underlying cause and we have to work on it. How they are receiving today, and how hard is for you as a fertility expert to reveal that?
Okay, so there are 2 parts here, like how difficult it is to ask for a semen analysis. Well, way back when I started my practice, it was a little bit of a challenge to convince the male that they have to get a
semen analysis
test done, because that's the only thing which they need to do. And if you understand, fertility is not that egg can regenerate to become a baby. You need a semen, and it's a 50-50. Whatever percentage you put, however it is, it's always a 50-50. So both are equally responsible. So that's how initially I would say almost 25-30% of the males would resist, say, okay, start karo treatment, we will see after some time, we may do it and all those things. But nowadays, they are quite acceptable, because I think they have a knowledge on how things happen and what is the necessity. But still, to an 5 to 6% will still resist and say, okay, no, you start the treatment, we'll see if things don't go well at the end of 1 or 2 months or 3 months or 4 months, we will try that. I always insist in getting a semen analysis because it's very easy.
Right,
You know?
right.
It's very, very easy. You're not, it's
not
non-invasive.
invasive.
Yeah, it's a non-invasive.
Yeah, yeah.
You don't have to go through any physical pain
Yeah,
like
yeah,
women goes
yeah.
through for all the investigation
Yeah.
which she has to. And once you're done, you're done. It's not that,
Right.
you know, you'd have to again and again
Yeah.
get the test done.
Yeah.
And once the reports are out, as I said, to what percentage do we see the semen abnormalities? As to the, if you look at only the infertility or the fertility couples, we almost like 35 to 40% will have some kind of abnormalities.
That's a quite
quite
a
number,
big
quite a
number.
number, sure. Because being in a fertility center, we have a very close look on the at the sperm parameters, and we also do automated. So because it should not be that, you know, we are giving some kind of a report which is not genuine. So we also do an automated one. Most of the time it correlates, almost 95% time it correlates to whatever our andrologist gives. So we generally try to give both the reports.
Right.
Yes. What we need to understand is how do we reveal, I would tell is, I generally look at each and every parameters and I tell them, okay, this is this, like liquefaction, volume, count, your motility and morphology. So we just tell these are all the parameters which have been assessed. So, and which is normal, which is abnormal. So we generally talk about the good parts first. And then come to the negative parts of it. Many times motility and the morphology. Then we again say that, you know, I generally, as I said, that the whole analysis has moved to a different paradigm now. So we try to tell that, okay, it is still possible. It's not that it can't be done. Though the chances are a little bit less. So you would rather take some amount of time on treating and things like that to improve the chances of fertility. And we also do what is called as, you know, analysis, in sense that if the abnormalities are there, then we need to do some blood test.
Right.
We need to do ultrasound to see if any reason which could be fixed. To tell you, almost 10 to 15% will have some kind of you know, sugar abnormalities. Unexplained because they have not tested before, so they are, you know, they have not done the test. So that's the most commonly seen. Thyroid problems and some kind of what is liver abnormalities is something which you have seen. So this forms the usual thing. Ultrasound, varicocele is the most commonly detected, but as I said, it's not a major you know, contributor to abnormal outcome. So as then our counseling goes to the next level. There's no reason why it should be like this. There is cycle to cycle variation. Day to day there is a variation. So what semen count we are seeing today, not necessarily it is there tomorrow or even after 2 hours if you give, it may not be the same. So rather be, you know, positive about it. Take this treatment. So what is the next? We need to plan things for them, right? Because you can't say, oh, it is all going to be normal, go home. वैसे भी नहीं हो सकता, not, and it can't be that, oh, it's all abnormal, you need to go to IVF. So we plan things like, okay, we will put you on some treatment, lifestyle changes, maybe some Ayurvedic treatment also, because we very, you know, under the core we believe that. And after 2 months, 3 months, if things don't work, then what is the next course of action?
Right.
If it is a mild to moderate abnormalities, we try 3 months normally, and we repeat the semen analysis. If the semen analysis is improved, then yes, we may continue to do normal thing. If it is not improved and it's the same, then we generally advise them to go for IUI. IUI, there is some amount calculation which we need to do, is the amount of what do you say, active motile sperms which you can see. Minimum criteria is 5 million motile sperms anytime when you're doing an insemination. But we've had pregnancy even with 2 million motile sperms. So it's not that we stick to this very much numbers that, oh, yes, it has to be minimum 5 million. Even if it is a 2 million, nothing is lost, considering IUI is not very costly or not very intrusive or invasive procedure. So we could still do an IUI, maybe 1 or 2 cycles, and see if things work. in an odd, maybe around 10, 15, 20% still conceive with that kind of an abnormality, which is pretty good enough for the things. Yes, if IVF also doesn't work, we will be thinking about IVF. But meanwhile, whatever lifestyle changes, whatever treatment changes you've done would have some kind of a positive impact on the outcome even in the IVF.
I think the stress on lifestyle and what they do between the process is something very important that you rightly pointed
Yes.
out. One more thing, be it men or women, it is very hard to take my parameters are this, right? So maybe it's there is a different way of showing it. Women might feel bad about it, men might get defensive about it. So as a fertility doctor, what is your friendly advice to all the men out there who felt crushed to know that some parameter has
we don't get into this kind of blame game.
Right.
Oh, your egg counts are low, so it's a problem of women. No, your uterus has a fibroid, so that's your problem.
Right.
Your semen count is low, so that is the reason. You are the reason. When you do that, then you get into this oneness of a blame game. So every time you'll be thinking, oh, you are the reason, so why should I take the treatment?
Right.
You take the treatment.
Right.
Or you take the. As I said, pregnancy can happen only if the egg and sperm are healthy.
Right.
So it's a team game. It's still not an individual game. It's like a nice two people in the team have to play. Both have to play well. If one starts blaming the other, it's not going to work. So yes, there is a magnitude of responsibility, maybe a bit different, but until unless both understand it, it's going to be a good outcome. That's the reason even if there's a bad some kind of abnormality which we see even in the women, we say okay, it still is that that's a combined responsibility, right? Only in certain reasons we're very sure that it's a male factor or a female factor. We do tell that it's a male factor or a female factor, but until and unless you play as a team player again,
it's not going to happen.
The end result is not going to happen.
And there is always a mindful way of telling.
Of course.
Also, there are a lot of forums where women speak about their fertility, their own challenges, and they are vocal, at least relatively compared to men. Men go through a lot of silent suffering when they are going through fertility treatments. What is your friendly advice? Like, how do you want them to think, like change their perspective?
I think they should also talk in the forum. As I said, we have our own patience issue. Like we're a very impatient one. Ego issues are there. But there's nothing lost when you talk to your friends and things. Everyone, see, it's always nice to compare yourself. So we generally compare with someone who's already performed or someone who's got a better marks. Or it's always a parameter that no one talks about unsuccessful thing. People only talk about what is successful, how successful I am, or how successful to him can I compare myself. To the fact this what is it called, test series, India got a washout, right? But then still we don't say okay fine, they're going to come back. They were so that happens. So what I'm trying to tell here is, when you look at fertility or infertility and the fertility index things, your friends may not tell you what they have undergone.
True.
And you may be feeling that, oh, I am the only person who is suffering here.
But there are millions of men out there.
Simple fact is, now the almost like the requirement for IVF is 18 to 20%. We have fertility of almost fertility issues of 20-25%. So that means if you're in a room of 100 people, 100 male, you have 20-25 who are not going to talk about it, but they still are suffering.
That's a big number.
That's a big number.
And there is a lot of silent suffering in there.
Of course. So you have a forum to talk about it. You could probably talk about it. I think nowadays we have been quite vocal and open about whatever we talk. Many a times in some of the forums we see is like, most of the time they talk about the performance. That's not the most important thing, because again I've seen many there was a few couples who have come like everyday intercourse or twice a day intercourse may result in pregnancy. So that is a lot of pressure. particularly on the men's side, because physiologically erection can probably happen once in 1 day or 2 days or probably even then. When you keep asking do kind of a thing, then the performance goes down. Then you lose your self confidence, and मेरे को कुछ नहीं, probably everyone is doing. I'm the only person who's not able to do twice a day or thrice a day.
Yeah.
But people who talk about it are the ones, maybe 1 or 2 in million, right? But then the whole thing goes in that I am not able to do it. So that's also not necessary. Even if you have contact once or twice in that period of fertility, we generally say have contact alternate day.
Right.
Or once in 3 days is also fine, but alternate day is good enough. Another major issue about the men's fertility is many people suffer with erection problem or erectile dysfunction, we see. But how does it start? It's a very interesting thing, out of all the 100 people which we counsel, most of them are more of it related to psychological. Though we do some hormone investigations, but then hormones and blood tests or sugars may be responsible for only 15-20% of the reason for having erectile dysfunction. But most of it is psychological. How it happens, it's very interesting. As I said, we all believe that every ball has to go for 6. Okay, every ball mein 6 marne. Okay, so we have a very good
maybe IPL really
IPL, all your heroes there. And another thing is which analogy which I would draw is when you have a net practice, you're brilliant. You're hitting all the ball wherever
no performance
pressure. Brilliant.
Right.
Failed pe gaye, out. Like that, how many players you don't know? True. There are lots of Indian players, or they're like domestic cricket or on the mat, they were really good. International level doesn't work. Okay, it's something like that. Performance pressure. It doesn't mean that you're something wrong with you. It's just that you're under stress to perform. Naturally, for everyone, everything, this whole act is very simple.
Right.
But what happens if you look at our this problem was not much, I would say around 30-40 years back, but then as of now it's too much. It's quite a lot there. Probably because of knowledge, the wrong knowledge.
Also,
the pornography.
Yes.
In pornography you'll see someone performing
wrong
hours together going on. Nothing is happening. And you say like, ye to normal hai.
Right.
This is the normalcy. Why is it not happened to me?
Right.
First thing first is this is the wrong knowledge.
Right.
That is not normal. That is one of the abnormal ways of sexual projections, things which people get carried away, and it's in your mind. And next, everyone fails once or twice, man. That is the rule of the law. I would say, or the nature, by nature, everyone, every man, once or twice in his lifetime will have erectile problem. But then if you put it here, that's when
what
it
is
starts
wrong with
becoming,
me?
It's only with me. It's only with me. No one else has. None of my friends have told about this. It's only me. How will I discuss with my friend? Boss, it happened to me like this. Will you tell, hey, it happened to me? No, hey, what is something wrong with you? Go get it. Even if it has happened 10 times to me, with him, he will not tell that it's, because for him it is an issue of his ego and personality. Obviously, he will be, teased. So, you get into this whole vicious cycle of thinking that this problem exists only with me.
But happening like erectile issue, happening once in a while, it is absolutely wrong, something wrong with me, is the common notion now.
It's a common.
So I think that is creating this vicious cycle.
Yes, and then again what happens is...
nobody will think this is normal, like if it happens.
That is normal. That's very, very normal. Very, very normal actually. Then next is another thing which we have it in our clinic. People go to, the clinic when the fertility treatment starts, the woman will be undergoing this follicular monitoring scans, and you say, okay, your eggs are ready. Now have contact or have intercourse.
Right.
And that's when she goes back home and says, listen, I've taken an injection, you need to do it today, or tomorrow, or day after tomorrow. That again creates all that, performance
you have
anxiety.
To do it
you
at
have
this
to
day
do it
only.
at this time, at this hour. You have to do. Why are you logging on to your laptop and working from home? Don't go to office, blah, blah. All that pressure from there. Here, pressure of this. So it's like a big pressure cooker. Right?
Poor guy.
And then you do not tend to do what is really necessary. So what we practice in our clinic is, yes, we say if your husband's okay to know when to have contact, it's fine, you can have. We're giving you tablet medicines, but continue to have regular contact. Don't stop till I say today is the day to have. Right? It may not be possible, may not.
That
He may not be
particular day.
Yeah. So as we know, once the sperms are inside the system, they're there almost for 48 to 72 hours. So it could still happen. So this performance anxiety is another big reason for erectile dysfunction. Most of the time, even if you do a study, 70 to 80% of them are psychological. 10 to 15% some hormones or sugar problems will be there. Only around 1 or 2% are the real case of erectile problem.
Right.
Other than that, 90% of them
Psychological.
will be psychological and the medical problem which can be treated easily.
So in that case, going for counseling, what is the intervention that will help to overcome that problem?
Kya counseling?
Nothing.
No, you tell me. The counseling is just positive reformation that this is normal. This happens to everyone. Now, when you start thinking that this is only happening to me, obviously you react in a sense that which is again an abnormal thing. It's like, we have seen so many depressions, anxiety. It's all because you're not open to talk about that, whatever failures or whatever success which has happened, or you're not able to express yourself. So basically sitting and having a dialogue, telling, yes, when did it happen? It happened this time. So one thing we try to do positive talking about it. See, this is quite normal. There are quite number of dietary things which can normally increase the testosterone in the body. I think the common
5
joke,
foods to overcome your erectile dysfunction.
That is also there actually.
Right.
If you see, drumstick is something which everyone says it's a good thing.
It's good for men.
Probably it is increased. So we generally send them again to the our Ayurvedic doctors who can modify the diets or something. They also, I don't think they're putting on any medicines. They're generally talking and telling how common this problem is. When you know this information that it is very common,
then you're calmed down.
You're calmed down. You're basically your nerves are calmed down. Next, another thing we suggest them is maybe the same place, same time, things is getting monotonous, and you're getting too bored, or your life is the whole sexual activity is only for fertility. Spice up your life.
True.
Fertility is a part of it. It can happen, but then if you're not enjoying that act, and you're doing only for chalo karte hain taki humko bachcha, we have a pregnancy and things, then it becomes very monotonous.
Keep the spark alive. Yes. Changes. Yes.
Keep the spice alive. Keep the spark alive. Then things may work. So change of place. Maybe go for another honeymoon, or probably go on a vacation and things like that, which could really well. And almost 70 to 80% of them are happy, fine, they get back to the normal thing. So it's just that this kind of a positive reformation, that's all.
You encourage Ayurveda. What is your practical experience? How Ayurveda helped with men's fertility conditions?
See, how we do it in our clinic, though you call it as Ayurveda, for us it is normal way of life. We basically have the Ayurvedic specialists with us who are in the fertility treatment, but they know like what food could change your hormones, your pitta, your dosha.
Bioenergies they talk about.
Basically, So basically certain dietary changes, certain increase in certain food things which can improve the hormones, and probably at what time, what things, they just modify that. They are not putting them on any kind of a medications. Probably if the normal treatment or normal advice or normal dietary changes are not impacting, they generally start them on
some
certain medication. But if you look at the composition, most of them are taken out from the nature. So basically it again improves your hormones and maybe the biomechanics of things. So we have not seen any much side effects of this. And I have not done any studies on it, but my patients do come back and tell, because when we put them on our own medicines, we have our own, we know what are the side effects. When initially they start with a very low dose and keep going up, they come and tell us that whether they are facing any difficulties or any side effects and things like that. Most of them have nothing, as we are, on a very, very, natural kind of way of treating. I would say it's more of a natural therapy than on any kind of
bringing back your bioenergies, bringing back your body to balance.
Of course.
Yeah.
Yes.
And I have particularly seen, like, because we also work with a lot of Ayurvedic consultants, there were medication regime, of course, apart from lifestyle routine, there were medications to reverse, let's say, varicocele grade 1, grade 2, not beyond grade 2. And, in general, correct bioenergies, in general, correct all metabolic functions or fatty liver or any other components to increase the sperm count, motility, morphology. So that Ayurvedic drugs also seeing good success. Have you particularly seen in any of your patients that those kind of Ayurvedic protocol also giving success and it really helped couples?
So I'm not looked into exact medications about my therapists are doing, but we have had good outcomes in sense that particularly when there is morphological as well as the motility issue. Even if you look at the medicines which we give in an allopathic thing, most of them are nutraceuticals.
Right.
Nutraceuticals means
the supplements.
Correct. So now we call them as nutraceuticals. Ayurvedic call them as aushadhi, whatever. So nutraceuticals again as a combination of medicines. Basically, most of our nutraceuticals are antioxidants. Okay, as I said, oxidative stress is more in the testes, so that's the reason which is causing the sperm morphological abnormality or motility problem. So we generally give them antioxidants, a combination of antioxidants, some work, some doesn't work and things. And in Ayurveda, it's almost the same thing with some more refinements or probably a little bit of more advice. So we've seen tremendous
basically
improvement.
Bringing the body back to restoration and then bringing back to normalcy as much as possible.
So whether I should tell this or not in this forum, way back.
Unfiltered.
Fine. So see, initially when we started our practice, because I've been there now almost like 2004 onwards, I'm doing this. During those days, we did not have any much treatment for male infertility. Okay, so we used to write some Ayurvedic prescriptions.
Oh, interesting.
And I was in Kerala. I started my practice there, and there were quite a number of our colleagues and all this. I think it came from the Ayurvedic doctors only. They used to write it, and so we used to write Ayurvedic prescriptions. To quite some time, people even thought that is an allopathic medicine. Okay, it was so well stocked in most of the pharmaceutical than on Ayurveda Shala. It was there in the pharmaceuticals. Okay, and it was under the brand of nutraceuticals. We used to write because that time we didn't have all this strong antioxidants what we have as of now in allopathy, or it's still in the nutraceuticals. So they already had it. That's what I'm trying to tell. So, and then over a period of time, I think
science
has evolved and
drug combinations come.
And that's how our Ayurveda has taken a backseat on this. But to really frankly, it has really worked. I've used it on my patients, quite a number of patients, because we didn't have anything at that time, so we had to use it. It worked wonders.
Lovely. This is super insightful, Dr. Sunil ji. Thank you so much for taking time and helping a lot of men out there. It really struck me when you said, how lifestyle is important, especially when the count is there or slightly lower, but morphology, motility is not in the right range. Then how you emphasized on trying naturally, having that patience and not expecting quick results, and how you pinpointed, how you told that you can't just pinpoint what is the exact reason in that person. It could be a combination of multiple other reasons. And that is thank you so much for that, and this could actually help so many people take an informed decision,
hopefully
not let them go directly to IVF as a first intervention, first line of intervention.
Exactly.
When it is not, when we should, there is no need to go
if
there.
it's absolutely necessary, you need to.
Of course,
we have the science for it. But yes, if there are so many things where there is ambiguity in it.
True.
But I personally feel that IVF should be kept as a last
line of
intervention. Yes.
And I always say this: doctors like you are truly a blessing, who encourage multiple options, tell pros and cons, and let couples decide, having a real informed decision in truest sense. Thank you so much for your time.
Thank you, Ravi. Thank you.